This conference will now be recorded.
Hi, everyone. This is Len Sierra for the Advanced AnCan video chat on October 16. I think that's all we say. And I'd like to acknowledge our sponsors, which Dr. John will read off.
Okay. We're grateful for the support, the unconditional support, I should say, of Pfizer, Oncology, Myriad Genetics, Foundation Medicine, Telix, Bayer, Janssen, I guess we don't have to say J&J anymore, and Myovant Sciences.
And Telix Medicine.
Yep.
Okay. Thank you, Dr. John. So let's get started with our new member, David Gerber.
Yes.
Oh, you know what? I'm just getting established here in my New Mount Kisco residence, and I didn't print out the questionnaire, so I'll just work from memory on it. David, how old are you?
67.
And when were you first diagnosed?
August of 2021. 2 years ago.
Okay. Do you recall your Gleason score and PSA at the time of diagnosis?
I was a Gleason score of 4 plus 4. My PSA was below 5. It happened to be that I had an exam and they discovered a large nodule in my prostate, on my prostate. So I went for MRIs and biopsies, and they confirmed that it was cancer.
Okay. And where did you go for that?
I'm from Jersey, so I was working with Teaneck Urology by me, and I ended up having my prostate removed, and I was
Is that 2021?
in 2021 October
Okay.
2021, 2 years ago. And then I was clean until I didn't have any signs of PSA until this summer, the end of the summer, the end of August, and it went up a little. And now, since there's PET scans and everything, and since some people in my family are doctors and everything, everybody said I should take a PET scan. So I had a PET scan, and they found some on my pelvic bone, where it spread to that, where that was what, yeah, my pelvic bone.
Okay.
So
That's it? Just that one lesion on your pelvic bone?
yeah, just one lesion on my pelvic bone. And we decided that I wasn't going to wait it out. And I started radiation treatment. I started it right after Labor Day, and I'm still doing it. I'll be done the end of this month with it. And I'm finding that a little hard, but it's pretty good because I have my ups and my downs. And plus, I'm on the Zytia medicine for 2 years, and I'm taking elder shots every 3 months.
Okay.
And I'm taking also the prednisone with it.
Right.
Yeah. I do have diabetes.
Okay.
And high blood pressure, and that's about it, I'd say.
I would talk to your doctor about switching to another drug because Zytiga is notorious for causing diabetes if you don't already have it, and causing hypertension. So that
Right.
might not be the best drug for you. You know, talk to your doctor about. Are you seeing a medical oncologist, by the way?
Yes, I am. I'm seeing Dr. Diamond, who's in Clifton, and he's part of Hackensack University Hospital, also here in New Jersey.
Do you know what your PSA was when they did the PET scan?
When they did the PET scan, it was 0.135. It was very low.
Yeah.
It was very low. I'm basically taking uh, nip it in the butt before it nips me in the butt.
Yep. Yep.
That's the procedure that I'm taking. To be honest with you, I do my blood sugar every day, every other day. My blood sugar, believe it, since I'm on a very stringent diet right now, because for the radiation, it's kind of amazing. I didn't think it was going to be a big deal, but you have to. I don't know if anybody is doing radiation, but you have to have a full bladder and a clean bowel, basically, and that's a trick for me because I said, wow, I'm gonna, I worked, I retired August 1st, honestly, from work, and I said, well, I was up all the time early in the morning, so what's the big deal? I could get up and do this until I found out what I had to do to prepare for it. So I used to get up 6, but now I'm waking up 5 in the morning because I have an 8 a.m. Treatment, which takes 10 minutes and everything once you go and everything. And it seems to be working. And I'm looking forward to getting through this and moving on in the end of the month.
So, do you know what type of radiation you're getting? Is it SBRT, IMRT?
Hold on one second, please. They have here FOSSA, FOSSA resource 1X 4839. I don't know. It's it's boost. They call it boost treatment.
How many
Yeah.
sessions do you have? Are you scheduled for?
Excuse me.
How many sessions are you scheduled for?
39.
Oh, so
IMRT.
they're not just getting your pelvic bone; they're doing their entire
Oh
pelvic
yeah,
region.
they're doing they're doing because they're doing my whole pelvic area.
Okay.
They're doing
So
my whole pelvic area.
just to make sure I understood correctly, you said you had the prostatectomy in October 2021,
Right.
and you were doing fine. So I assumed you were not on any therapy, but now you say you've been on Zytiga for 2 years. So
No,
um,
I was on nothing. I was on nothing. I was on nothing from that time until uh, Labor Day of this year, approximately.
so that's when you went on Zytiga.
Yeah.
Okay.
And my big question is, how do they know when that I'm really all cured? Because I'm going to be on the Zytiga till you know two two full years, and you know, do I really know
So,
that they cured everything?
so
Well,
cure is a word you've got to get out of your vocabulary, Mr. Gerber.
Okay.
We cannot we cannot ever assure you that you're cured. The
Right.
best we can do is assure you that you have a durable and continuing remission.
Right.
That's the best that we can hope for. Because with this disease, even if we get your PSA down, and when you come off the hormone therapy, it stays down, it could always come back because we don't yet have the science and the technology to tell you you're cured, meaning it's gone
Right.
forever and it'll never come back, right?
Right.
I think your question is, how can they assure me that I have a continuing remission? And the answer to that is tricky because, as you rightly say, you're on hormone therapy, and so it's artificially depressing your testosterone and hopefully your
Right.
PSA, and it'll begin to rise later on.
Right.
You know, my own situation, I also I didn't have surgery because the likelihood was that it was not going to be successful, and I'd need radiation anyway. And when eventually I came off of the hormone therapy, my PSA rose for 11 months before it fell.
Right.
And thank God it did fall, and it's stayed low for the last 14 years, or the last 12 years, I think.
Right.
So,
Well, I'm sorry.
you go ahead.
Well, right now my PSA, because they did a PSA test already, and my PSA is undetectable again. It's below,
Well, it should be.
yeah, because of the hormones and everything.
Right.
So
So,
and since I'm doing all this, I'm on, because they're watching the liver and everything. I never had any problems or anything, but I'm on every other week of blood tests right now and everything to check. So
which is good.
it's being watched very carefully. I
Right.
got to say, my doctors are really, up on it.
Well, yes and no, because they're following you, but as Len said, with a history of high blood pressure and diabetes, we often see doctors put people on drugs other than Zytiga, although Zytiga is probably the first choice drug, or abiraterone acetate.
Right, but that's what.
So, and there are guys on this call, and they may want to speak up momentarily, who have been switched because of their blood pressure, because of their heart issues, and what have you. So I do think that it's a very reasonable discussion. I don't think I know Dr. Diamond. I think we might have had somebody else at Hackensack. Who started? Ben? Didn't Ben start at Hackensack? I think he did before he switched to the city. So I'm not sure. Does Dr. Diamond only work with genitourinary cancers like prostate and kidney and testicular and
Yeah,
all of those?
yes, he's
Okay.
working only with that. And I go to the New Jersey Urology Center, Dr. Gitterman, Gitterman in Saddlebrook. That's where I'm having my radiation every day.
Is that the Sloan Kettering branch in Saddlebrook?
No, that's part of Hackensack University.
Okay.
And I do my blood pressure every day. I do my blood sugar every day. And believe it or not, my blood pressure, well, now that I'm not working, my blood pressure is with him has dropped and everything. So been really very lucky with that. My blood sugar has actually dropped also from what it was when they first did all my tests and everything. So I feel like I'm comfortable. The only problem is that I'm constantly having diarrhea. That's
From the
my biggest.
radiation or are you taking metformin?
Yes, I'm taking metformin.
What's the dose?
I'm taking um, 1,000 things in the 1,000 in the morning and 1,000 in the evening
And
milligrams.
Right.
when did you start that?
About a
Recently?
couple of years ago,
And
at least.
did it bother you before you did it bother you before you started the radiation?
No.
Go ahead, Len.
Okay. So you're pretty sure the radiation is causing the diarrhea then?
Well, that's what they think. That's when I was speaking to the technicians today about it, because I said, sometimes in the morning I have a rough morning, and I have it in the morning, and then during the day I'm all right, and then sometimes it depends on what I eat for dinner. Uh, I could either be good or not good. It's been very
Are
up
you
and
eating
down.
are you eating a very bland diet? Eating all the kinds of foods that you normally shouldn't eat, like white bread and pasta. In other words, low fiber. When
Oh
you're
yeah, I'm
getting
eating low fiber.
radiation,
Yeah,
low
low
fiber. Okay.
fiber and definitely all that. And I have a question about the Zytiga. I'm taking it once a day. Uh, what is the? I gotta get the dosage.
It's 1,000 milligrams. You're taking four 250 milligram pills.
No, I'm just taking one.
Oh, okay.
One with a low fat diet in the morning. We're doing that route.
Okay. All right. Good.
You know, so I'm doing that just one in the morning, 250 with low fat diet, and
So a question for you. Your Dr. Diamond, what's his first name?
uh, uh, whoops, hold on a second.
Is it
Elan,
is it
Elan Diamond.
yeah. Okay, I have him. Yeah, but they show him as being at Holy Name and not at Hackensack.
Well, no, he's in Hackensack now.
Oh,
He
he
used to be
must
at Holy
split.
Name.
I see.
His office used to be in Teaneck. Now he's over in Broad Street in Clifton.
Mm-hmm. Mm-hmm. Yeah, and he is a GU med onc. Okay, that's why you're confused. That's why you're confused us here. But we got
Right.
him. We got him. Um. So yeah, I mean, it's not unusual. How long have you been in radiation treatment?
Since right after Labor Day, I am up to
6 weeks.
yeah. Basically, I have another 10 sessions left.
Sessions.
Yeah,
Look,
and
it's not unusual to get the runs during the radiation treatment, but it is for 6 weeks.
right.
That's
Well, no, it
that's
did start right away. The Well, I don't know. Honestly, at the beginning, I was very uptight and very nervous, and it felt like it was maybe nerves that was making me have it. I don't know. It's just
okay.
very strange, everything.
Which town are you in New Jersey? We got a lot of New Jerseyites on
I'm
this
in
call.
Teaneck.
Oh, you're in
I'm in
Teaneck.
Teaneck.
Well, we got one of our moderators. He's not on tonight. Is also in Teaneck. So so that's good to know. So you want to open it up, Len, and see what
Yeah,
other people have
yeah,
thoughts on this,
absolutely.
on the
Why don't we
runs?
start with Dr. John, since you were on Zytiga and you had problems with your sugar and your blood pressure. Give your experience to David.
I started out with abiraterone and prednisone just like you did. And it went okay at first, but after about 8 months, my legs start swelling up. My blood pressure was out of control. Cardiologist kept adding more and more blood pressure medicines. I was on 4 of them. But when my legs started swelling up like that, um, they took me off it in favor of a different drug, and all those side effects went away. I did get mild diabetes from it as well, and I went on low dose metformin. Um, and My diabetes indicators improved after being on metformin. I'm still on it.
Yeah, well, metformin
And
is like I understand is like the real one for it.
it's a good drug. And then I also had diarrhea from my radiation therapy, my IMRT. I didn't have any for the first month, and then it came in as the second month.
Hmm.
It got to be pretty bad and sometimes pretty sudden. And I did the whole dietary modifications, just like Len was talking about. The nice thing was that after I finished my radiation, the diarrhea cleared up fairly rapidly within a couple of weeks.
Okay, that's what I'm looking for. I'm glad to hear that.
Dave, this
David,
is
I've
this is
tested.
Peter. I have a quick question. Did they scan you at all before you did your prostatectomy? Did they do some basic CT scans or anything like that that might have
Oh
picked
yeah,
up this stuff?
yeah.
And they didn't see
I,
any
I
metastasis at that time in
no,
your
no.
belly.
Everything was clear. Everything was good. I had a PET scan back then, uh, which the PET scans were completely different than the PET scans now.
Right.
What I had one back then and everything, and there was nothing else there.
Probably had a bone scan too at the very beginning, I imagine, because
I don't
that was common
recall.
practice.
Yeah, most probably I did
Hmm.
because I most probably did because I went for so many different things at the beginning,
Hmm.
back in 21, and now
David,
I
I wanted
just
to
went to.
ask you, did you have any specific questions you wanted to ask our group?
Basically was what should I expect next?
So I'd like to ask you a couple of questions, and I'm on the same regimen you are currently. Uh, I get Firmagon injections monthly. I'm on abiraterone and I'm on radiation.
Right.
Um, I'm not familiar with a dose of 250 milligrams of abiraterone with a low-fat diet. I am familiar with 250 milligrams with a high-fat, moderate fat diet where you have increase. The reason when you take abiraterone on an empty stomach is because you don't want to eat fat, which would increase your absorption dramatically. So, could you just maybe explain the 250 on a low fat? I'm not sure you're getting enough abiraterone.
Supposedly, I'm only taking about 5 grams of, I think 7 grams of fat with it. I take basically in the morning, I take the pill and I take the cortisone and I drink 2% milk and then I have a little cereal with it and that's it. And they claim that it's enough because at first they said, well, you take it 4 times a day and everything, and I really didn't want it that way. And then I heard that this is something new that they're doing.
Yeah,
The 200.
let me interrupt just in the sake of time, because Dr. Jeff, we have always heard of it as a low-fat diet. Most guys who are taking 250 will be taking it with what they consider to be a low-fat diet. So I think the confusion here is between the low-fat and the high-fat. The low-fat, and this goes back many, many, many years to going to a lower dose. I mean, I remember going to them first trying this lower dose maybe in 2014 or 2015. And we've always heard of it as being, I believe, and I'll stand corrected by any other of the moderators here, but we've always heard of it as being a low-fat diet.
With 250?
Yes.
Yeah.
That doesn't make sense to me, though. If you take 1,000 on an empty stomach, if you take a quarter of the dose, you're gonna have to take it with something to increase the absorption, like fat.
Yeah, but it's still a low-fat. I mean, am I wrong, Len? Is it or Dr. John? Isn't it a low-fat diet that the guys always take it with? You're muted, Len.
I don't know how that happened. Yeah, the trial was run by Dr. Shmulewitz as a phase 2 with a low-fat diet. That's what kicked off this whole idea that you could get away with just 250 milligrams of abiraterone. I have never heard of taking high-fat diet. Matter of fact, I have read that if you do take a high-fat diet, you might get too high a dose of abiraterone.
Right. Right.
Okay, so David, I want to ask you for your email and also how to find AnCan.
Excuse me?
David,
Yeah.
did you hear the question?
Well, my email is gerb, GERB, 445 at optonline.net.
Sorry, Gerb 445 at what?
Opt, OPTONLINE.net.
Okay, so we'll get you signed up to get a reminder. And how did you find out about us, David?
I went on to a support group from Holy Name Hospital, and they mentioned it. So I looked into it.
Great. So the other thing we should mention for everybody is that we also have a really good, if you're still dealing with any anxiety, we have a terrific group that meets. The next meeting will be next Thursday or this Thursday. This Thursday. We call it Men Speaking Freely, and we talk about everything and anything except treatment. And it is a really good group. Sometimes David Muslin and Dr. John run it. Sometimes Rich Jackson runs it. He's not on the call today, but I recommend the group. I'll sign you up for it as well, just to get a reminder. So it's only getting the reminder. If you don't want it, you have to go to take it off online. Don't just unsubscribe, because if you unsubscribe, it'll take you off of everything. And then I got to write to you and say, oh, are you sure you wanted to leave this group as well? But I think you'll like the group. Nobody has asked you about exercise yet. Are you exercising?
Yes, I am. I'm taking
Good man.
I'm taking a light exercise class offered by the Township of Teaneck 2 days a week. It's basically with weights in your hands and stretch cords. Plus, I walk every day. I try to walk at least a mile or two.
Okay. Well, we may
Because,
have an exercise buddy for you in Teaneck.
okay.
I'm gonna connect you with Ben Nathanson, who's not on the call tonight, and
Okay.
maybe we can get you an exercise buddy, because it is so much easier to exercise when you got a buddy.
Oh,
Maybe you
yeah.
can get Ben to the light exercise class in Teaneck as well.
Yeah. Well, it's very nice. I went into the class. I told the instructor what was up when I knew what was up. And he says, "Are you allowed to do it?" And I said, "Yes." I cleared it with the doctors because I asked them. And the doctors said, "Well, that's the best thing for you, is to do
Okay.
exercise and keep your body really moving." And I'm doing it. Like tomorrow, I have my treatment at 8 a.m. No, today's Monday. I have lost my days. On Wednesday, I have my treatment at 8 a.m. I'm home by 10 to 9. I'm out of the house at 10 after 9, at class at 9:15 to
Excellent.
10:15.
Okay, you sold us. But we
All
got to
right.
move on, because I know we got another new guy.
Yeah, yeah.
But
Okay.
First,
you're
Jim Marshall's got his hand up, Rick.
Go ahead.
Yes, yes. David, are you a veteran?
No,
Okay, I think.
no, I'm not.
Okay.
Okay, Peter, did you have your hand up?
Yeah, I just want to quickly say, Dave, that while the goal for you might be remission, the long-term goal is keeping an eye on this.
Oh, yeah, that I know.
Almost all of us on this screen have disease that we've been watching and treating and this and that for 3, 4, 5, 7, 9, 10 years. So it is a manageable disease often at your level, but because you've already had metastasis, it's as Rick said, it's not going to be cured, and you're going to have to keep an eye on it and keep in touch with that medical oncologist, because he's going to be your guy here on out. So have regular checkups, regular blood work and stuff, and probably regular scans every year or so. Just keep an eye on this to don't turn your back on it, because it
Oh,
is
no, I'm not.
manageable as long as you don't get flippant and think you're in the clear.
All right, we're going
Like,
to go to Chuck Snyder next. David,
thank you.
come back next week. Thanks for sharing your story. And we're going to go to Chuck Snyder.
Hi guys.
Hello.
Hey, so Chuck, you heard the routine, but I'll repeat the questions for you so that we keep you on track in a chronological order. How old are you, Chuck?
I'm 61.
Okay, we do have would he be eligible for the under 60 group, Rick?
Barely. Barely, but we wouldn't kick him out. When we sign you up, we'll send you the under 60, and we'll send you the men speaking freely, but just adjust them on the website if you don't want to be on them. Okay?
Okay.
And by the way, we take your emails because we send out reminders before every meeting. We do very, very little in the way of using them for fundraising. Once a year is the only time we come ask for money. We're not like some of the other groups, so don't be afraid, okay?
Okay.
Okay, so while we're on that topic, why don't you give Rick your email address, Chuck?
Okay. It's Chuck W. Snyder at Verizon.net.
Got it. Thank you.
You're welcome.
And Chuck, where do you live?
I live in Lavallette, New Jersey.
Okay. And when were you first diagnosed? What was your Gleason score and your PSA?
It, I was diagnosed February of 2019, and the Gleason score was a 9. I'm not exactly sure what that 4. I think it's 4+5.
Okay.
I think it was, yeah.
All right. And your PSA when you were first diagnosed?
It was 35.
Okay. And what was your, did they do the scans like MRI, bone scan?
Yes,
Yeah.
they did
Ultrasound.
bone scan and CT scan, and I had an MRI of my spine, and they found I had 2 tumors in my spine, T4 and T7, I believe, and scattered lesions in my lower spine, very small, and then my lymph nodes, seminal vesicles, and the prostate, of course.
Pelvic lymph nodes?
Pelvic lymph nodes, yeah.
Okay. So what was your primary treatment, your first treatment?
They put me on Zytiga with Firmagon, and I was,
Okay.
yeah.
And that's it? And no radiation, no surgery?
I did have surgery on my, they call it kyphoplasty on my spine. I had 2 cracked vertebrae, and they filled it with cement. They call it kyphoplasty,
Right.
just to stabilize the vertebrae. And they did recommend radiation, and I'm kicking myself. I decided not to do the radiation because I was studying all the statistics. You know, what the benefits were. With and without radiation, and that there didn't seem to be much benefit for doing the radiation. That it only gained you a few months of additional life. So I decided not to do it at the time, but I did end up doing radiation last year, March of 2022. I did do the radiation just to the prostate, but I'm kind of wishing I had done it earlier. It may have helped me a lot better than, 'cause right now I'm in a bad situation, I think.
So when you had the radiation, what was your PSA at that point?
Uh, let me see. See. I think it was around, my PSA was always very low. It was probably around 0.64, something like that. It
And
was
then
always
after
very low.
radiation?
Um, yeah, it did slightly dropped after the radiation, and then it quickly started to rise again in August of 22. So
Okay.
yeah, after I completed it, it started to rise to 0.64, but before that, um, I'm not sure what it was, maybe 0.2 or something like that. But
And where is your PSA right now?
right now, I just completed chemotherapy in docetaxel, 10 rounds. I completed that in July, and before I started the chemo, it was 3.5, and after completing the chemo, it went down to zero point 0.1, and 3 months later, it started rising rapidly to 0.6. It's right now 0.6. So,
Okay.
and I had
Um,
Sorry, go ahead.
Yeah, so all this time you're on Zytiga and Firmagon?
Yeah, I've been on yeah, I've been on ADT. I switched from Firmagon to Orgovix. Um,
Right.
but I stopped the Zytiga because I became castrate resistant after I think 2.5 years or so. So I
Right.
stopped the Zytiga, but I did continue the ADT, which is Orgovix.
Right. So, what about your family history, prostate cancer or breast cancer?
My mom had got breast cancer very late in life. In her 85, she got breast cancer and passed away last December. It had spread to her ovaries and intestines and everything.
Right.
So, but there's really no history of prostate cancer. I know my grandfather. I think my one grandfather had. I don't think he had prostate cancer, but I think he had BPA, enlarged prostate. But so he went through some kind of treatment. But there's really no history of prostate cancer in the family.
Okay, and did they ever order any genetic testing,
Yes,
germline or somatic? They did
yep,
both,
yes.
both germline and somatic.
I'm pretty sure
And
I did everything, and I wasn't eligible for I didn't have the right gene to be eligible for that one medication that is known to cure prostate cancer. I didn't have that gene, so
you mean the PARP
Cure,
inhibitor, olaparib?
not cure, Mr. Snyder.
Yeah, no cure.
It,
well,
it can be used to treat if you have a certain gene, but what I think what we're asking is that there are two types of tests. One is to see if you've inherited anything, and the other is to see if you've made anything in your own body. And they should have done both of them. And the more interesting one to us right now is, and to ask your medical team, whether you've had somatic testing. And if you haven't, it definitely should be ordered. And that's to see if you've developed anything yourself. So that's called a somatic sequence. And they can do it either with blood or from a recent tissue sample, which they may be able to find. Where have you been treated, and what's your history with your treatment team?
yeah, I'm being treated at NYU Langone in New York City,
Okay.
and yeah, I've been with the medical oncologist since since I was diagnosed in 2020 or 2019,
Okay.
and
Who's the oncologist there?
David Wise.
Yeah, we certainly know of him. And now you've got Zalewski there. He was the chief of radiation oncology at Memorial Sloan Kettering, who's come over. And
Okay.
and we also have one of our advisory board members, Dr. Stacy, is also. Have you come across Stacy Loeb? She's great.
Well, that sounds familiar because I have a consultation to start Pluvicto this Friday, and
Yeah.
I think she sounds familiar.
No, she's not the Pluvicto lady.
Oh, she's not? Okay. I know it's a woman I'm talking to, so it could be another
Okay.
woman there, but she's a radiation oncologist. So,
Okay. No, Dr. Stacy Loeb is a urologist, but she's very
oh,
big on lifestyle and health and exercise and all that good stuff.
oh,
And how
So
are
that's,
maybe
you
you need
doing
to
with
look her up.
exercise and diet?
yeah, let me write her name down. Yeah, because
We'll
I'm
put it
very
in.
into,
I tell you what we'll do. We'll put it in the chat window for you, and you can also find her on our advisory board. and you can tell her that AnCan sent her, and she'll smile.
Okay.
She's really terrific, and she has a radio show, and she does a lot of stuff, but she's
All
very
right.
well respected. And by the way, for the new guys, the chat window are the two little squares in the top right, and you can open that, and there may be messages in there for you already. So I'm just putting Stacy Loeb's name in there, and I sent that to Len. I meant to send it to everybody. You'll find Dr. Loeb on our advisory board as well, if you look at that. So
I just ask a question here, Rick. The only chat messages I see are from you. If there are any other chat messages being posted, somehow I'm not seeing them at all. And I
no,
think it's probably because
I don't think there are, Len, because I don't have any other ones.
oh, okay, fine. I thought maybe it was because I'm using the browser instead of the desktop app.
Same here, no messages, just the
No,
room.
they've
Okay,
been quiet. They've been quiet on the messages. I got a message from Mr. Muslin, but that's okay.
all right. So Chuck, you just told us that they're scheduling you for Pluvicto.
Right.
Did they discuss any other treatments that you might try next besides Pluvicto? I'm just curious.
They at one point he mentioned a clinical trial, you know, combining Pluvicto with a immunotherapy drug, but the latest recommendation was just to try the Pluvicto, and then if that didn't work, then he also mentioned another chemo, Gentiva or something, Jevtina. That sound familiar?
Jevtana.
Jevtana, that's
Jevtana.
another chemo
Yeah.
drug, like it's similar to docetaxel. Uh, so did they do a test or a scan to see if you're PSMA avid?
Yes, I
And
had a
you are.
PSMA. Yes, and my pelvic lymph nodes were, they after the chemo they started getting bigger, and there was new pelvic lymph nodes that showed up, and the thing is, all my spinal metastases seem to have disappeared. They haven't shown up in any scans for I don't know, for a long time, and I'm thinking maybe I never really did have any metastases in my spine because I'm thinking maybe I just in the beginning I was seeing a chiropractor, and he was very rough on before I got diagnosed. He was very rough on my spine. He was really putting a lot of force on my spine, and I'm thinking maybe he could have cracked my vertebrae, and it showed up on the MRI as possibly a tumor, but I'm thinking it could have been just a broken vertebrae from the chiropractor.
So, Chuck, I mean, it's essentially a good sign that nothing's showing up there for whatever reason.
Yeah.
But there is something that we'd like to suggest you talk about with the radionuclide physician who you're going to meet for the Pluvicto. And that is if they haven't done it yet, when they did the PSMA scan, did they also do an FDG scan? Because this is controversial, but our experience and what we've seen overseas, especially in Australia, is that they do both scans around the same time. And the purpose is to try and make sure that all of the lesions that they do see are PSMA avid. Because there can be situations where you may have both non-avid and avid. And it's good to know that before you go in. because it may affect your treatment choice. Now, there are radionuclide docs, including some we respect really well, like Tom Hope, who doesn't see the need to do it. But at the same time, he's not the guy who's talking to the fellow who only got half of his lesions treated and he just doesn't know what to do with the other half of his lesions because they've left him by that time and they've gone back to the medical oncologist. So a discussion that we strongly urge you to have with Dr. Wise and this lady is, we call it concordant. Do my PSMA scans agree with the FDG scans? And then that'll give you the information you need to decide if you want to pursue that or not. And I'm pretty sure, given you're at Langone, I'm pretty sure that Dr. Wise has done somatic testing. But if he hasn't, and if he has, ask him for that somatic report, and when it was done, because if you were tested for somatic 2 or 3 years ago, they need to test you again now. They need to repeat that because it changes over time. And you might not have been a candidate for that special drug, the one you were talking about before, which is called a PARP inhibitor, but you might be a candidate today for that PARP inhibitor. Things change over time. I see, Peter, you have your hand up.
I'm going to go a different direction. Since you're only 62, Chuck, are you on Medicare disability, or do you have really good insurance? How are you dealing with this?
I'm still working. I'm not on disability. I work full time still, so I do have very very good insurance. Yes.
Okay.
So, Chuck, do you have any questions for the group before we move on?
I guess my one question is, I mentioned it earlier that I didn't choose to do the radiation earlier, and I'm wondering if I had done that. I keep hearing about this debulking. You know, they do the radiate your whole pelvis or your whole abdomen. I'm wondering if that would have cleared up these lymph nodes, which kind of showed up later on in the later couple years later. They kind of got bad. But I'm wondering if I had done the radiation of my pelvis earlier, could I have been in a lot better shape than I am now?
Okay, well, I'm going to jump. I'm going to jump right in here because I'm going to ask either David Muslin or Dr. John to address that. Who would like to take that one on? Mr. Muslin or Dr. John? Dr. John, you switched on your mic. Give this gent an answer, please.
Well, I'll give you an answer that's not really there's no, we don't know. We don't know what, in retrospect, whether having radiation back then would have made you worse or better. I kind of doubt it, but what Rick is really, I think, picking up on is something that we call treatment regret, and it can really be a bitch. When we think back to something and imagine that it might have changed the course of our disease in a really meaningful way, and we start, agonizing over it. One of the things that people who adapt successfully to having cancer master is not looking back, because it doesn't help us. We don't know how things might have turned out, and it's very painful to look back and have regrets. I personally, maybe one of the reasons Rick picked me is because I look back and I think, oh, I wish I didn't have my radical prostatectomy because it didn't help me and all I got was these lifetime side effects. And so I even today, I had that thought, we look forward. We 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 look at the present. We live in the present. We move into the future, and we do our very best not to look back. Um,
Okay.
imagine like people with lung cancer thinking about all the smoking they did, and and the effect that might have on their quality of life in the future. So
Yeah.
I don't think anyone can answer the question about whether radiation would have made a difference or not, or would have made you worse, or whether you made the right decision or the wrong decision. But we do know that that probably the more you wonder about it, the more it will diminish your quality of life.
Okay. Okay. Thank you for that. And if I have one last question, if I may,
Yeah.
Let me just follow up just to help you a little bit, and then you come back. In 2019, the fact that they offered you radiation was fantastic, because a lot of hospitals, when men came in de novo metastatic 3 or 4 years ago, they weren't being given the opportunity to debulk the primary. So the fact that they did it is really kudos to NYU Langone. Most likely, and unless they told you otherwise, if they were going to debulk you, most debulking was the gland, only the gland,
Mm.
and not right across the pelvic girdle. Now, we have seen guys that got debulking right across the pelvic girdle. There were a few, but if there was a protocol at that time, it would have only been the gland, which you got in 22. So the fact is, it may not have been that different. And the fact is, we can't change it.
yeah,
And I'm thinking that you've got good docs there, and they
yeah,
got and they're looking out for you.
right. Okay. Oh, that's comforting. Thank you for that.
And
Alan,
if
Yeah.
Beth,
if it if
you
it
have
was
your hand
clear
up.
that you were making a wrong decision, your doctors would have stepped in and said, "No, we're
Right.
not we're not going with that plan."
Okay.
And it wasn't clear. Len, sorry.
Yeah, I was just going to tell Alan, who had his hand up. Go right ahead, Alan.
Okay, well, two things. Yeah, I wanted to put off radiation with my medical oncologist, and the radiation oncologist, yeah, they jumped right on it. And they said, no, you got an aggressive thing here. And the other thing I wanted to throw out to you too, there's a neat little course on great courses called it's cognitive therapy for everyday life. It's just really a neat course that teaches you about thinking and what your thoughts and how your thoughts can trip you up. So, if you're one, I'm one for taking courses and watching videos and doing all that kind of stuff. If that's up your alley, you might want to consider that.
Okay.
Can you put the
Yes.
name? Can you put the name of
Yeah,
it
I'll
in
get
the
the right
chat?
name, put it on. Yeah, we'll do that.
And
All right.
Gary
Thank you,
Peters, you
Alan.
had your hand raised.
Yeah, I know you have another question, Chuck, but while we were still focused on you, I just wanted to ask, how is the kyphoplasty working out for you?
It's really I have no problems at all with it. No pain. It was a simple procedure. They just went in and made two little incisions and put a needle in and filled the vertebrae with cement. And I had I recovered quickly. I had no pain. I haven't had any pain back there at all. So, and it's they say it lasts for I don't know 20, 25 years, which is a lot longer than I'm going to be around. So, yeah, I was very happy with it. Yeah,
Great, thank you.
you're welcome.
And David Muslin, you had your hand raised.
Yeah, two things. We really don't know how long we're going to be around. You're still a young guy. You might be around in 25 years. You don't know. Number one. Number two,
join us on Thursday night for Men Speaking Freely. You get a lot of that kind of stuff out, a lot of regretful stuff, and we all talk about how we feel. And it'd be great if you join. I really welcome you to join us on Thursday night.
All right. Thank you. I'll do that. Thank you so much.
Yeah, it's good stuff.
And you had another question, I think, Chuck. What's your last question?
Oh yeah, I was wondering if I had radiation just to the prostate once, is it possible to have, if, I think I asked my oncologist this, is it possible to do radiation again if I decided to do the lymph nodes later on? Is that possible doing radiation twice, or somewhere I heard that it's not, you can't do it twice or something like that.
They could radiate areas that have not been previously radiated. The question is, how effective would it be? And would you be better off now, for example, with Pluvicto rather than doing external radiation? And
Yeah.
after you've had the Pluvicto, then there's a question of how much more radiation. So again, a discussion for either Dr. Wise or whoever your radiation oncologist is. I'm assuming it's not yet Dr. Zalewski, but he would be a great person to ask, is how much radiation, external radiation, can I get after Pluvicto? I honestly don't have, anybody know the answer to that one?
I think there are a lot of dependencies, Rick. One of which is, what's the collateral damage going to do? Are you going to be damaging or further damaging the rectum or colon area from which may already have been affected by previous radiation? So it depends on the location of the lymph nodes. There's no cookie cutter answer to that one. But Rick's right. I would try and get an appointment with Zalewski. He's new there, and I'm sure he's swamped with new patient requests. But see what you can do. Maybe Dr. Wise can put you at the head of the line to speak to him or consult with him.
Okay. All right.
Chuck, thanks for joining us, and we hope to see you again.
Thank you. Thanks for all the information. Appreciate it.
Okay. You're welcome. We're going to go to Joel Blanchett, who has an update for us. Go ahead, Joel.
Yes, I have a question and an update. Does anybody know where Dr. E went last week? Was there a major prostate cancer conference or someplace she might have gone? Because I wrote her 4 emails and I haven't heard from her yet. So, anybody know? Okay. My update. As you know, Dr. E decided last time I saw her in early August to have my L4 and T6 and T9 radiated. I believe she found some dormant sleeping prostate cancer in those places. And she told me to tell my radiation oncologist, which I did. He did a thoracic and a lumbar MRI on me last week and found out there was possible cancer in L4, L5, T6, and T9. So she got 3 out of the 4. And so he's now planning to radiate me thoracic spine in November, 3 to 5 sessions of SBRT. And in December, he's going to radiate my lumbar spine. T4 and T5 happened to be right next to the left iliac bone, which I was first got radiated 2.5 years ago, and he is putting that last because he says I need to let that to heal some more. I guess because there will be some radiation overflowing back to the left iliac bone in addition to killing the cancer in T4 and T5. But there's no, as far as the PSMA PETs are concerned, there's no cancer left in my left iliac bone. So that's the update. I'm going to be going through that in November and December, and then we'll let you know what goes on.
So, Joel, how many spots are they actually going to hit?
They're going to hit
Four?
four spots total, two on the thoracic spine and two in the lumbar spine. And he can't do them all together, but he will do them two separate occasions. So it'll be, he hasn't decided yet. It'll be either 3 or 5 sessions each. And so Dr. E is wants an appointment with me on 9 November, but I'm not sure if that's a virtual appointment or a in person. That's one of the questions I asked her last week, but I don't have the answer to that yet. And then she wants to see me back in early February, where she's going to give me the same battery of tests, the 3 MRIs and the PSMA gallium scan that she gave me back in early August. So she'll want to compare the results of those two
So
batches.
is he going to do spot radio? Is he going to do SBRT, or is he going to use EBRT?
No, SBRT.
So it's all going to be done with SBRT, and this is in the DC area. You're going to do it in the
Virginia.
Delmarva area.
Yeah, Dr. Eblin in Virginia. Yes, he's the one that did my radiation on the left iliac bone and my right occipital condyle bone with a knife. And I even asked Dr. E if I should go to Johns Hopkins for the radiation. She said, no. She says, if he wasn't that good to radiate those 2 spots and kill the cancer, I want him to do it again.
Okay. I think there was an ESMO conference last week because I saw a couple of papers come out, but I'm honestly not sure. So if there was, then the likelihood is she was in Europe.
Right.
But I'm not sure. I'm not certain. You can check. Go online and put in ESMO conference and see what ESMO prostate cancer and see what comes up if there was something going on last week.
Got it. Thank you.
I will say, I will just say very quickly, we were in touch with her and she was amazing at the end of last week because she helped us resolve an issue with Alexa, and she went to one of her colleagues and came up with a fantastic solution, and it looks like that solution will work in terms of helping us diagnose whatever's wrong. So God bless Dr. E again. So go ahead, Len, sorry.
I just wanted to know if anyone had questions or comments for Joel. If not, we will move on. Thank you, Joel, and we'll move on to David Muslin.
Yes, thank you, Len. I just want to bring everybody up to date. So I took a drug holiday, stopped the darolutamide about 2 weeks ago. And Shmulewicz was totally behind it, no problem. Just curious, how long does it take for I know it's different for everybody, but I'm still getting hot flashes and it still feels like I'm very much on it. How long do you think it takes for that to come out of my body, to wear out?
I think it depends on your testosterone recovery.
Yeah.
In large measure. You know,
the Darrow might be gone already, but the effect might be long.
My testosterone's been at 500, 600.
And you're still getting hot flashes.
Yeah.
Huh. I don't know. Anybody else got suggestions about that?
No, but I think we should bring Harry Spieler in right now because his questions are really around the same thing. So it would be a good time to bring him in, Len.
Okay. Go ahead, Harry.
Are you there, Harry?
Yeah, I'm here. I guess it's definitely related. I'm just curious as to testosterone recovery and its role in easing some of these side effects. I was taking Zoladex and darolutamide together, and I stopped taking the Zoladex in March of 22, so it's over a year and a half. I'm still on darolutamide, but my testosterone is very slow to recover, and I'm kind of surprised at that. I thought it would recover quicker because my understanding darolutamide doesn't block testosterone the way Zoladex does. And when I had a drug holiday some years ago when I was on Zoladex, my testosterone was at 300 after a year, and at 18 months now I'm still under 100. So and Rick was kind enough to send me some information to read, and that looks like, you know, some men just don't recover fully, or it takes a long time to recover their testosterone. So just curious what everybody else experienced.
David, how long did it take for your testosterone to come back when you went to monotherapy on darolutamide?
Mine came back pretty quick. I think I can look exactly, but I think it was 3 or 4 months, 6 months at the longest, 3 to 6 months, and it's pretty high.
Yeah.
How old
And
are you, David?
I'm 68.
And Harry, how old are you?
I am 63.
Wow, interesting. Guess we're all a little different.
Yeah.
Yeah, just to show you the opposite, it's been 15 months since my last Eligard injection, and my testosterone has only gone up to 20.
wow. But you, Dr. John, you were on monotherapy darolutamide for a while as well, were you not?
No, no,
Or you were?
I took that last Eligard shot in July, and my darolutamide ran out a few weeks later.
Okay. So to go back to David's question, and so we'll try and tie these two together. I don't know that we have the experience to know how quickly darolutamide goes out the system in terms of having its impact on the androgen receptors. I mean, maybe one of the docs here does. Maybe Carlos or Dr. John or Dr. Jeff might know better. I certainly haven't seen anything on it, and everybody is different. It's like the story on the testosterone. Your testosterone came back relatively quickly. Harry's is not coming back. So I don't know there are any hard and fast guidelines. Anybody in the group want to address these issues? From experience or from knowledge?
I just
I
have a
don't. I don't
question.
think there's any answer. I don't think there's. I mean,
Everybody's different.
some young guys have low testosterone. Some guys in their 30s and 40s. I mean, there's no way to predict this. I've been
I
off of
have
these
a question.
drugs now for 2 years,
Hold on,
and
Jimmy.
I can't get over 100.
Yeah.
Yeah, the conventional wisdom, as you know, Rick, is that it depends on your age, how long you've been on the hormone drugs, but it's just a guide, and like we're all saying here, everybody's different.
Is
I
there?
just
I'm
want
just
to
curious.
ask
So
a
does darolutamide keep testosterone down? I thought it didn't, because that's the only difference between the last time I went on a drug holiday was I just stopped Zoladex, and my testosterone went up to just about 300 in a year. In 2 years, it was at 500. And the only difference this time is I'm only on darolutamide. So I'm just surprised that it hadn't gone up this time like it did last time.
I was on darolutamide before I started the Orgovyx, and my testosterone kept going up, and I found out that darolutamide upregulates the receptors, and it's going to continue to go up. And I guess depending on the age, I'm older. How much of it was bound to protein and other elements, I think made a difference. But the ADT, once I started that, I started getting hot flashes like I never had on darolutamide alone. The Orgovyx, I have phenomenal hot flashes on, but I never had it on darolutamide by itself. And I don't know if that was related to the fact that I just kept getting higher and higher testosterone, and now I have no testosterone at all. So I just trying to understand David's situation. He was just on darolutamide for a long time. He was having hot flashes, and I'm wondering, David, if you had hot flashes more so when you were on ADT prior to just being on darolutamide by itself.
Yeah, I kind of don't remember, but I've always struggled with hot flashes. But like we all know, it's different with everybody.
David, my question, I want to ask a question, David, please. My
Yes, sir.
question is, your testosterone is up around 500,
Yes,
but
sir.
you still have significant hot flashes and fatigue, you say. That's the two main things?
Not the fatigue so much. The fatigue seems to be lightening up a little bit, but it's
Ah,
just the hot flashes.
oh, okay, okay. And yet Harry, very much, very low testosterone, hot flashes also. But, right, Harry?
Yeah, I have hot flashes, but I also developed something called hyperhidrosis during treatment. I've had it for over a year now, and it's intense sweating. Your body kind of overreacts to stimulation that makes you sweat, except it kind of goes crazy. So,
Is that separate from
um,
hot flashes?
yeah, you may. I think you could confuse the two to be the same, but it's not. They're not the same. There's a
God.
difference. But yeah, I developed that, and I sometimes wonder if other men may have developed that also, and are thinking it's hot flashes. But
That's
anyhow,
terrible. I'm sorry.
Cliff
And then
Collins, you had your hand raised. Oh,
the other thing that I was dealing with, that I'm still dealing with, is gynecomastia. And a lot of guys don't have that issue, and I do. And I don't know if anybody can answer this question. Will getting off of their lutamide, will the gynecomastia stop growing? And if I have the surgery, which I'm thinking about doing, will the surgery stop the growth as well? That could be a tough
well,
question.
surgery certainly, yeah. But if you
Carlos could
stop
answer.
if you stop the medication, it's not going to shrink the breast tissue, but it shouldn't get worse.
Right. That I would expect. But rest, yeah, yeah. And you think if I have the surgery, they won't come back at all. Obviously, if I have to get
Right,
back on
because you're
darolutamide, will
removing
it
that
come back, or they just take, or is all the tissue's gone and it can't grow?
exactly.
Got it.
What's his
Okay.
name? Wassersug. He told us he had a double mastectomy,
Yep.
and he's not going to have.
So did Al Latimer.
That's right. Yeah.
And that might be the
Now,
next
David,
step.
don't you have that Embr Wave device?
Yes, sir.
Doesn't help.
Never leave home without it. It helps a lot, actually.
Oh,
It
okay.
stops the hot flash in its track. But at nighttime is when it doesn't work great, and that's where I struggle.
Okay.
Right.
For me.
And I just, since we're mentioning it, there's a couple of new guys on here who aren't familiar with the Embr Wave. I know Jeff is not. It's spelled EMBR, Embr Wave, and it is a wrist. It goes on your wrist, and it can help control hot flashes. It works for most guys, but it doesn't work for all guys. And we can fill you in on that maybe in the next session or what have you, because I know we're running a little late. The only thing okay, go ahead, Carlos.
As far as the Embr Wave goes, it works for me. However, it took about 3 or 4 months before I actually found that it was the positioning because they say put it on your wrist, but there's actually a 2 or 3 centimeters from the actual crease that works best for me. If I have it too low, it, for whatever reason, isn't doing what it needs to be doing to feed back to your brain. So anybody who's tried it and is not so sure it works so good, just adjust it up or down a little bit and try it. And David, did you reprogram yours to go overnight? Because it's got a long program that goes on and off.
Yes, yes, it doesn't help. For some reason it does not help me at night.
Okay.
Did you have any other input on the darolutamide, Dr. Carlos?
You know, I'm a little confused on that whole topic because my understanding was darolutamide was a androgen receptor blocker, and it's my understanding that it's blocking the cancer cells. How that falls into what we're hearing, I can't put the two together. And my situation is a little bit different in that I did start developing gynecomastia when I started using estrogen patch to control my. I think you'll have to let me know if you got me. Okay, am I back on?
Yeah.
Okay. We hear you.
Okay. So that was an adjunct that has been useful. However, I did start developing breast buds and a lot of pain, tenderness, for which I started tamoxifen. And I basically stopped the patch and dealt with the hot flashes for about 2 or 3 weeks, and then started back on the patch. And that's been able to help me manage. And I've had hot flashes 5 out of the 7 years or so that I've been on Lupron. So I'm just one of those that's going to be sensitive for whatever reason. Again, I'm also on darolutamide. I don't know how that's going to impact either item, but I do understand that the Lupron is your biggest resource, biggest source of the cause of gynecomastia. And once it has developed, undoing it is usually not a simple item, and some people do revert to surgery.
Yeah. You know, the tamoxifen for me, it was holding it down a little bit, and I was really dealing with some extreme fatigue, and I got off the tamoxifen for a while, and my breast took right, and the gynecomastia just started to grow really fast. It was very interesting.
Okay, and you're not on estrogen patch?
Nope.
Nope.
Never took it.
Okay.
Never did.
You know, I've seen different things. I was on 20 milligrams for a better part of 3 or 4 weeks before I switched to a baseline 10. It's just hard to find somebody who, other than those who've tried different things, none of my docs are aware of any of these items, and they've never suggested how to deal with it, which is unfortunate because I've got to go try to ferret it out and then listen to some of our speakers here in the past who've talked about estrogen and how to apply it.
Right.
I get a Depo-Provera shot about every 3 months. I've had no hot flashes for the last 6 days. I usually get 8 to 10 a day at least. I'm not on Depo-Provera. I know Rick doesn't like it, but the fact is it works. It does take 10 days before it becomes effective, and you have to get a shot every 3 months, but it just cut my hot flashes down to nothing. And I've been doing it for 4 years because I really get bad hot flashes. And I've had as many as 25 in a day, and I'm down to 0. So it's just a thought. Depo-Provera works.
All right, guys, we do have a lot of other fellows who'd like some time. So, David, okay with you if we move on? Can anybody hear me?
Yes, I can hear you.
We hear you.
Oh, okay. All right, so I'm going to move on now to Dennis Correa.
Hello. Yeah, I had my annual scans up at Mayo a couple weeks ago and got clean results. stuff that had showed up before no longer showing up. They did both a technetium head-to-toe bone scan and then the CT of the pelvic, abdomen, and chest. And they all came back clear. They could show where some of the previous lesions were, still show something there, scar tissue or whatever. And my PSA was still been at non-detect level, less than 0.1, and not really having any issues. I mean, this was just my regular scan that I go for every year and reviewed with Dr. Singh. And his recommendation is just to take another break from the drugs. Concerned about the long-term use of the androgen deprivation, the adverse effects of that. I have started to see a little bit of cognitive issues sometimes and short-term memory type stuff. And I think that's a potential issue from the Abbey. And also my blood pressure has been higher than usual, up into the 150s and so forth. So all of these are potential. And to improve my probability for a little longer term survival overall is to take another break and wait till PSA rises to 2 and get the PSMA PET again, and then make a decision again when it shows up, where is it and how are we going to treat it. So I'm okay with that. You know, I just I didn't request this thing necessarily, but this was his suggestion before I got to ask about it. But otherwise, I'm doing okay. You know, I don't have the I don't get the recovery for my testosterone when I take it, when I take the breaks like I did before back in 20, I think it was. And so the hot flashes, you know, just maybe I've just gotten used to them. You know, I'll get a couple during the day and maybe 3 at night, and they don't last real long. So I could deal with that.
Have you agreed? Do you have an agreement with Dr. Singh as to what level you're going to return?
Yeah, 2. PSA 2.
Okay.
So I don't know that I'll get, I think the first one I took, I got maybe 8 months before it started to get to that point, approximately. So I don't expect this one will be as long. If the information I've read every successive time, you generally get a little bit less time before your PSA gets to a point where you need to react.
It would certainly be a good idea before you go back on to do a PSMA scan when your PSA is at 2.
Yeah, that's what he suggested.
Great.
Yep.
Well, this is all good.
Yep, good.
Right.
I had no complaints. Other than getting older, I guess, at times.
All right, Dennis, thank you. You're doing well.
Any questions for Dennis going on a drug holiday? Okay, go for it, Len.
Dr. Jeff Gilbert, you are up.
No, I'm good. Thank you. I nothing.
Oh, I thought you wanted time. Okay.
That was it. My question was answered.
All right, great. Then we can go to Spencer. Spencer Field, are you with us? All right, we'll go back to Spencer. Let's see.
He should be on.
I know his mic is on, but Maybe he's not hearing us or he stepped away.
Well, his mic is gray. What's that
Yeah,
mean?
it's kind
Yeah,
of weird.
it is right. Yeah.
Spencer, if you can send us a chat message, let us know if you're still there. Meanwhile, we can go to Joe Commando. Is he still with us, Joe?
Hi, yeah, I'm here. Um, I was just watching a video by Dr. Scholes from the PCRI last week, and he seemed to entertain rather comfortably a strategy that I'm wondering about. So I'd like to ask about that. Um, Basically, you take PSMA tests at regular intervals and then shoot whatever you find with radiation. Um, I'm keeping it simple. Does anybody have thoughts about that?
Well, it's so general and so vague, it's kind of hard to
Okay.
comment.
All right.
I
Well,
think.
that's actually what I've done. Well, I took my first PSMA test last spring. I don't think it was available too much before that. And I've done that twice, in effect. First time it was with Axon PET scan, where they found a lesion on a whatever you call it.
Lymph node?
What lymph node? Thank you. Uh, and they zapped it, and then they did that again this summer after the PSMA PET scan. Um, so maybe that adds a little more to it. I don't know what more you want from me.
So, this is sort of relatively new ground. This metastatic um, directed treatment, MDT, metastatic directed treatment.
Okay.
It's usually done in conjunction with hormone therapy. What you're looking at is what we use the highly technical term, and we have 4 doctors on, so they'll really understand it. It's called whack-a-mole,
Right.
um, and the problem with whack-a-mole is that it's not systemic. Interestingly enough, the there is a theory that the radiation can have a what do they call it, Len? The ablative effect, is it?
Abscopal.
Abscopal effect. Thank you. The abscopal effect that that makes other treatments more effective. But you know, I don't think anybody can say it's a good or a bad strategy. What we do know is it's not going to get allow you to control the disease for any length of time over the long run. So anybody else want to talk about the success of whack-a-mole? Len, you've been around this for years and years. You must have some
Well,
thoughts on
as far as I
whack-a-mole.
understand, the literature states that MDT, as you called it, metastasis-directed therapy, uh, certainly prolongs progression-free survival, prolongs biochemical recurrence, but I don't believe it's ever been shown to prolong overall survival or cancer-specific survival.
Yeah, but the MDT studies are all with hormone therapy.
Yeah.
Are you aware of any MDT studies without hormone therapy?
No, I don't believe so.
So, you know, the issue here is, what about MDT without hormone therapy?
And let me throw a fly into the ointment. For many, many years, that was considered by some a useless process because it was still systemic, and our abilities to find cancer sites, really, the quantum leap when PSMA came out. I haven't seen information on that approach since PSMAs have come out, but I've had some guys. I was playing whack-a-mole with my radiology people, and their approach was, you know, it buys you time, but it's just a matter of where the next one's going to pop up. And then comes PSMA, and where I was supposedly oligometastatic, you know, 3, maybe 5 lesions, there was 10. So it's like, well, okay, so really we can't see the littler ones. We can only go after the ones we can. So kind of flips back to what you're saying, Rick. Without systemic treatment, you know, what are we really doing? So
Right.
I don't know.
Yeah, no. I mean, I agree with you. I mean, that's why we see the two together, Joe. And I mean, I'm interested. I mean, Peter? Are you the only other Schultz person on here tonight, or is there anyone else?
I don't know.
Have you ever had any whack-a-mole discussions with Dr. Schultz?
I've never had bone mets, but but I know Dr. Schultz. Dr. Schultz has a lot of patients that are pretty strong-minded and self-directed. That you know, even with high PSAs, don't do any hormone treatment and don't do anything. And you know, and he doesn't push people. You know, he's found that some people go for several years with no treatment at all, and before they have to do anything or want to do anything. And so he's had second thoughts about, you know, whether to push people on to treatment right away or let things go and just radiate when necessary. So I think he's a pretty liberal guy that way.
Joe, just to answer, I think, the question that you had, now that you're probably getting PSMA scans, now that you can see these things when they're millimeter in size, maybe it's a whole lot more useful than before when they had to be big enough to show up on a scan.
What are you thinking there, Joe?
I think he's.
I'm thinking, I'm getting the sense that you guys are pretty leery of that as a strategy without hormone therapy, understandably. And, you know, so you're not as comfortable with it as Dr. Schultz appears to be, I guess, if I understood him correctly.
Well, you see, the problem is we're not sure how comfortable Dr. Schultz is with it, except
No,
for
I
certain
understand.
situations. I mean,
Right.
it's very specific. I mean, I think what you're hearing Dr. Carlos say is, you can do it and you can try it, but you got to be really careful that all of a sudden it doesn't get out of hand, and then you're behind the 8 ball. You know, it's not the same situation, but you don't want to be where Chuck Snyder is today, where he's worried, well, should I have done it, or should I have started earlier, or if I'd have started earlier, would this have happened? And that's always what's going to happen when you're going after whack-a-mole. Yeah, it might work, and you might be one of the lucky guys that could control the disease with whack-a-mole, but there are no clinical trials that I'm aware of, and there's some much better read people in this group than me, but there are no clinical trials that tell us that whack-a-mole alone is going to control the disease. And that's really, I think, what we're saying to you. So if you've got a good constitution and you want to try it that way, you may minimize the side effects, but you may suddenly find it's gotten out of control, and then what are you going to do? Is that a fair, Carlos, Dr. Carlos, is that a fair summary?
I think that's a reasonable summary, but yeah, the backup plan is if it starts to, PSA starts going up and you start seeing more lesions, your plan B is get back on systemic treatment.
Right.
Yep. Tough one. And you know, you've got to get someone, either you've got to sign up with Dr. Schultz and get him to find one of his colleagues in Philadelphia who will work with him, or you've got to find somebody in your area who's going to buy into that, Joe.
Right. Thank you.
Sure.
Okay.
Just can I just say, Harry, I sent you a private note in the chat window.
So, Spencer, I see you're back with us. You're up.
Okay, thank you. Yeah, I had a significant amount of computer problems, but I'm back now. Can everybody hear me okay?
Yes, sir.
Okay, great. Sorry about that. My last visit with the oncologist was about 3 weeks ago, and at that time my PSA was higher. It had been around 2, and it was at 3.5. And so he sent me. So he said, "Let's maybe okay, and not to worry about it, and we'll see what happens on the next visit." But he did send me for another PSA test after the appointment, and and it went up to 7. So now he wants to see me again next week. Actually, it's the end of this week. It's the 20th, and he said that he thinks he's going to change me, get me off of the abiraterone and put me on something else. But what I don't understand is the abiraterone and the what's the other thing, the injection
Omegon?
is
Lupron?
Lupron, yeah. But that's keeping my testosterone level close to 0. So isn't that doing what it's supposed to do? So changing the abiraterone, is that going to help any, or am I, or I guess I don't understand. But I mean I'll talk to him about it on Friday. But I wonder if you guys have any insight into that.
I'm sorry, you said changing to abiraterone from what?
No, changing from abiraterone to something else. He didn't say what.
Oh,
Well, he'll tell me that Friday, I suppose.
well, I guess
So,
because you've been on abiraterone and your PSA is rising, so you're resistant to it.
Uh-huh. But I thought the purpose of the abiraterone was to get my testosterone level down to 0, which it is.
Well, yeah, that's true. But you're also taking the Lupron, which can keep your T level very low.
Right.
Without, I don't know, how are you tolerating the Abby? Was there much fatigue with that?
Yeah, there's a decent amount of fatigue and a little bit of the sweats, but nothing serious with the sweats.
What is your PSA now?
7.
And what was it before?
Well, it was 2, and then at the last visit it went up to 3, and then a week later it went from 3 to 7.
Well, that's probably why he wants to switch. Not
Yeah.
your testosterone, your PSA.
Right, right. But isn't
Did he
that
tell you what he wanted to switch to?
no? He'll tell me that Friday when I see him.
Oh, okay. All right. Well, you'll
So,
have to come back after you talk to him and see what it is he wants to switch you to.
okay, so
Okay,
let me
okay,
explain it. No, nobody's really explained it. So let me try and explain it for you, Spencer.
okay,
We start off
okay.
taking two drugs. One is the ADT, the Lupron, or you wanted to switch to Orgovix, it would have done the same thing. And what that does is it blocks off the testosterone. But the
Right,
cancer gets clever and it figures out another way to get testosterone. So we have to come up with another drug, a second drug. And that drug is for you, first time around, was the abiraterone and the prednisone. Okay?
right, right.
Eventually, that drug stops working too. Even though you're taking both together, it's still not controlling. And we've seen that because your PSA's gone up from around 2 to around 7. You're in that place right now. So now we have to see,
Yeah,
maybe there's another drug that could work for you. It could be if he's going to put you on another drug, you ask him for darolutamide. Tell him you want darolutamide because that's going to have the least amount of
darolutamide.
side effects. Okay, darolutamide. Somebody will put it in the chat window for you. All right, and
Okay,
it's also called Nubeqa. Nubeqa is the commercial name. And that's probably what he's going to talk to you about. He may suggest enzalutamide or apalutamide. The one you want is darolutamide. They're all pretty similar, except darolutamide has the least amount of side effects. Okay?
okay, okay.
And that's where I think I think you're at. That's where I'm guessing you're at. Now, if for some people, and it's not that many, they do get a response. It's around 10% of people get response with enzalutamide. I don't know what the numbers are for apalutamide or for darolutamide, but you may get a response after the abiraterone, and that's what we're hoping for. If that doesn't work, then there are other drugs that we can be. There are other protocols that he can discuss with you. This is with Testa, right?
Right.
Yeah. So, let us know. Let us know what he says, but I suspect that's what's going on with you. Does that make sense to you?
Absolutely. Thank you. I appreciate it.
Okay.
Can I ask
Okay.
another question?
Sure, go ahead.
Okay. Also, as part of the last visit, I was complaining about my having a lot of rectal pain from the tumor and the prostate pushing up against my rectum. And he suggested I go through a short course of radiation just to shrink the prostate enough to alleviate the pain. So he, so he recommended a radiological oncologist, and I saw him, and he did it. He said, "Well, if we're just going to do that, we might as well go and irradiate everything." So he had me do another PSMA PET scan, and he just started me on a treatment of 15 rounds of radiation, uh, and uh, so he said it's kind of half palliative and half treatment to see how much it can shrink the tumors. But he's going to try to get everything he can, but I don't know, I don't know how well that's going to do. But I'm 4 treatments into the 15 treatment regimen now.
So you never had a primary
No,
therapy?
no, no. I
Okay,
started on the anti-androgen therapy from the beginning. That was
right,
last December.
right. Yes, that's kind of what we were talking about before, debulking the primary tumor. And in your case, it's not only treatment, it's also palliative because it's causing rectal pain.
Yeah.
I wonder if they can put in a spacer. You know the spacer technology.
Oh, yeah. Yeah.
Maybe they could shove that in between the prostate and your rectum to protect your rectum from the radiation. Although you already started it, I don't know if it's too late or not.
I had asked him about it, and for some reason or other, he said he didn't think it was the right thing to do.
Okay.
He didn't
So
really explain.
I was told that big prostate tumors where they have to shoot a wider angle of radiation, the spacer gel would not protect the colon. It's for the
Mhm.
smaller ones where you put the gel in, and then it can protect the colon. I was not
Okay.
a candidate because I had a big tumor.
Yeah. Right.
Okay.
Okay.
So a couple of things occur to me listening to the second part, which is that you may want to just stick on the Abbey for a while and not make any
Uh-huh.
changes until you finish your radiation treatment, and then
Okay.
see, because we're not really going to know what's going on since you're now in the middle of radiation. So we won't know the amount of success. You could start darolutamide, your PSA could shoot down, and we wouldn't know if it was the darolutamide or if it was the radiation.
Radiation.
So
Right.
it's
Yeah.
so you've got to be testers should know that, and
Mhm.
so you need to be sequencing this next treatment, bearing that in mind. The second thing is that when you come off how long have you been on the abiraterone now?
Since last December.
A year, almost a year, 10 months.
Right.
So you gotta come off that prednisone slowly,
Mm.
and hopefully Dr. Tester's going to talk to you about that if he takes you off. So you got to come off very, very slowly, because that can have some significant impact on you too. The abiraterone you
Right.
can stop, but the prednisone you got to really taper off gently. And some of the docs rush you off the prednisone in like 2 weeks,
Mhm.
and we've seen guys have a lot of problems when they get off that quickly. I mean,
Really.
I
Yeah.
don't know. You got the doctors on this call, so they can advise you better about tapering off prednisone. But I'm just saying, be very, very careful.
Well,
I don't,
I thought that the idea of the prednisone was to replenish the cortisols that the abiraterone was taking away from it. So it was like a net zero effect. So I don't know. I haven't talked to the doctor about this at all, but I thought that once I'm off the abiraterone, I could go off the prednisone immediately because I won't. The
no.
cortisol.
It doesn't
Adrenals. The
the
adrenals,
adrenals.
they'll take some time to recover from the suppression from the Abbey. That's probably why they
Okay.
want you to taper the prednisone.
Thank you, Len.
Okay.
Yeah.
Okay, thanks. I appreciate it.
You can't just stop and then the adrenals pick up and make all the cortisol tomorrow. They've been
Uh,
suppressed for 10 months. So they got to have
right.
time to wake up. And in some men, it takes longer, some shorter. Dr. Jeff, you got your mic off. Well, you're on, rather. What do you want to say on this one?
Well, realistically, the purpose of the prednisone is to suppress ACTH you, so that you don't produce too much aldosterone. The problem is, the swelling and the hypopotassium state is we make too much aldosterone because there's too much ACTH around. So yeah,
Mm,
you're taking it to replace the cortisol, but you're also taking it to cut that ACTH production so that you don't have excess aldosterone. That's why people's legs swell up and get hypertension and low potassium, and we definitely don't want that.
Mhm. Does the darolutamide also require the prednisone as well?
No.
No.
No?
No.
Oh, okay. Okay.
All right. Well, I had my own update, but it's kind of late. I don't know. Should I go
Go
ahead,
for
Rick,
it,
or wait?
Okay.
Go,
Is that
Thanks very
go,
much. I appreciate it.
go for it, Len.
all right? So there's actually two issues. First one is a question for all of you. Anyone ever had a Zometa infusion? Zometa is a bisphosphonate, which is sometimes, well, in women it's used for osteoporosis. In men with prostate cancer, it's used to preserve bone strength and hopefully prevent metastasis. So nobody here has taken Zometa. I
Well,
guess I
I
wonder if
have.
Jake. I wonder if
I
Jake.
have.
Oh, you have. That's right, Rick.
Right. But I did it. I only did 3 infusions. I wasn't doing it every 6 weeks or 3 months or what have you.
Right. And you had no
But
problem.
and I think after the second one, because I was getting it annually to support my bone mass, but I think after the second one, I might have felt a little crummy, but nothing like you had. Anybody else? Gary, did you get Zometa?
No, but I was anxious to hear Len's experience because I'm on Prolia now, and I'm reading that having a Zometa infusion is the new wave of thinking in terms of locking in the gains from these bone strengtheners when you go off them. So somebody going off Prolia would
Right.
get a Zometa
Let
infusion.
go back to Len. Go ahead,
Yeah,
Len.
you're exactly right. You're exactly right, Gary. And that's why I had the Zometa infusion. I had been on Xgeva for 4 years, and I was starting to get a little worried about the increased probability that I might get osteonecrosis of the jaw, even though the percentage is still low, maybe 10% after 4 years on Xgeva. So I had a discussion with my oncologist, and I showed him this paper from an endocrinology journal that said what Gary just said, that if you stop taking Xgeva or Prolia, it's the same drug, different dose, you lose all of the bone density gains that you have made within 2 years, and most of that loss occurs in the first 6 months. So the strategy that the endocrinologists prefer, as Gary said, is you stop the Xgeva or Prolia and you give a one-time infusion of Zometa to lock in those gains that you made in bone density. So what happened with me is I stopped Xgeva, I had the Zometa infusion, and I was fine for a few hours afterward. And then by the evening, I started feeling kind of flu-like symptoms, low-grade fever, a little bit of chills, just, aches and pains. So I went to bed early, woke up about 2 hours later with uncontrollable shaking chills, like you hear about the people with malaria get. And this went on for over an hour. I didn't think to bundle up and warm up myself before that hour because my ears were hot, my head felt hot, but I was still shaking like a leaf. So after an hour and close to an hour and a half of that, I was exhausted. I said, I've got to do something. So I went to my closet. I put on sweatshirt, sweatpants, got underneath a warm quilt, and finally the shaking stopped. So I was just curious if anyone else had that reaction. I just spoke with my oncologist earlier today about that reaction. He was like, "Yeah, we've heard about this before. I've seen it before." He said, and that's why we stay away from that drug whenever possible. So that's why most oncologists will prefer to put you on Prolia, Xgeva, and not on Zometa. Now, our dearly departed brother Jake was on Zometa for years, and apparently, he tolerated it well. So the reaction that I had is not common, but it does happen.
Right.
And that's the end of that story. So then moving on, I had a PSMA PET scan because my PSA was rising. But actually, at the time of the PET scan, I had a PSA test the same day, and the PSA was only 0.17. And as we heard from someone else earlier today, they had a PSMA PET scan at 0.13, and it showed some lesions, and so did mine. So you don't need to wait too long for your PSA to be rising before you should try and get a PSMA PET scan, see what's going on. So I had I had all small lesions. They were all sub-centimeter, but there were 3 lymph nodes lighting up, and there were 2 bone mets lighting up, left and right posterior iliac bone, which is your hip bone. Dr. O suggested I try and hit the 2 hottest lesions. One was 25, one was 19. The only problem with radiation, the only problem with the doing that is that one of them, and I wanted to ask Peter about this, one of them was the para-aortic. And I think, Peter, didn't you have a para-aortic lymph node light up?
It was pretty close to my heart, so I opted not to do SBRT, and I went for proton radiation for that.
Right, proton. That's what I was thinking. Maybe I should do for that one.
Well, at least
because I asked Dr. O, I said, "What about this?"
Get a second opinion from a proton guy if there's somebody there.
Yeah, definitely will. I mean, what complicates things a bit is I'm heading down to Florida in 12 days, so I can't get anything done in the New York area. So I'm going to ask Dr. Guanchel down in Sarasota if she can recommend someone. And Dr. O gave me the name of somebody in Miami. I forget. I wrote it down now. But I don't know where I've got it, but
Alan Pollock.
Oh well.
Write that down. He's very good. Alan Pollock at Sylvester.
Oh, that's the guy, Jack. Thank you. Yeah, Pollock.
Yes.
Very good. Yeah. So what is that? University of Miami Hospital?
Yeah, Sylvester. He's the chairman.
Sylvester, it's called?
He just does prostates. Yeah, he's really good.
Okay. You know if he does proton beam?
He is in charge. He triages that. We have a proton center, and he is the one who calls the shot on whether or not you should go there or do SBRT or whatever. But he will be the guys in charge of allocating you to go and do proton rather than SBRT or something else. He calls the shots.
Okay, yeah, very good. Thank you, Jack.
Sure.
Len, I have a question. Does the loss of benefit from the Prolia also occur in patients who go off ADT?
Yes. Yes, because the study that I quoted was actually a study done in postmenopausal women. And it's funny that the oncologists on the prostate side aren't aware of how the female oncologists are treating women who are going through treatment that causes osteoporosis, because it's very common knowledge for the women to have their doctors tell them, well, you've been on Prolia for 3 years now. I can't continue that. we're going to give you an infusion of Zometa, lock in your gains, and then you're done, because they're concerned about the possibility of ONJ. It's almost like a standard practice for them. So anyway, that's my update, and thank you all for.
Hey, hey,
Oh,
Len.
go ahead.
I really want to thank you for giving us that insight into your experience with Zometa, just so we have an idea that if it happens to us, it probably is supposed to happen, and that seems to be self-limited, but I don't know that it's preventable. That's always the big question. So appreciate that.
Sure,
Yeah,
and just keep in mind, it's not common. It's uncommon to
yeah,
have that reaction.
it's really rare. I mean, I think I've known one other person since I started doing this work who had a really bad reaction to Zometa, and that was at a time. I mean, Xgeva was approved, I think, around 2012, 11 or 12 or something like that. And it really didn't get wide adoption for another 3 or 4 years. So you're always fighting, were you going to get Xgeva? Were you going to get Zometa? Xgeva was probably a little bit better, but. So a lot of people did get Zometa. That's why Jake, God rest his soul, was on it for so long. But I only knew one person, but we knew that it had flu-like symptoms. But I never heard anything. I never actually heard it until last weekend when my fratello, he came down like a ton of bricks with it.
Yeah, the reason it shocked me was because after being on Xgeva for 4 years, I never had any reaction whatsoever, nothing. And I'm also not allergic to any medications, never have been. I have no allergies of any kind, so it was really unusual. Jolie, you had your hand up. You're muted, Joel. Joel Blanchett.
Talking about me? No, I didn't. I might have been wiggling
Okay,
my
David,
hand, but
David
Yes.
Muslin, you have your hand up.
Yeah, so Len, so what's next? Are you going to go back on ADT? What are you going to do? What's your plan moving forward?
Yeah, Dr. Rose suggested going back on darolutamide monotherapy, which worked well for me uh, for about a year and a half, 2 years. Actually, it was 2 years, yeah. Plus the possibility of the spot radiation, depending upon what the radiation oncologist has to say.
Right, right.
Well, I'm gonna talk to this guy Pollock at Miami and see what he thinks.
Okay. All righty. I'm following in your shoes. You know that.
Yeah, right.
Let me ask you a question, Len. Were you forewarned about this side effect, or did anybody tell you, prepare you for this?
No,
Oh,
nobody
so,
said anything.
and you stayed home and you took care of yourself by bundling up, and you didn't panic and say, I got to go to the emergency room or anything like that?
No, I wasn't at that point yet, but it was
Oh,
mostly just fatigue from constant shaking for an hour
oh,
and a half.
oh, God. I mean,
There's no pain per se,
but
just
you weren't worried about dying or anything. It wasn't that bad.
no.
Okay, all right, all right. The way you
But maybe that's
described it,
because
it
I'm
sounded
naive. I
horrible.
don't know.
Oh, no, no,
No. Dr. Jack,
no,
Lynn
no.
does not worry about dying. That is the
Yeah.
first thing. You don't know our Len. He doesn't
No,
worry
I
about
don't.
dying. And he and I did speak, and he told me Zometa, and he's got some flu-like. And this was when he first got the flu-like, before he did the shaking, because I called him the next morning. And I told him, I said, yeah, it's a known side effect, the flu-like things, but really uncommon. And then I called him the next morning and said, how are you? And he said, you wouldn't believe last night. I had the worst night. And that's when he brought me up to date with the shaking, the shivering and the shaking.
All right, I'm glad you're
Yeah.
okay.
I guess
It
when it
sounded
comes
scary
to,
to me. It sounded awfully scary the way you were describing it. Suddenly, these
yeah,
uncontrollable shivering overcomes you, and it comes out of nowhere, and it didn't sound like the ordinary flu. So I just didn't know if you were thinking, God, this is a prelude to something more ominous, but you didn't panic. You stayed cool. Congratulations, wonderful, and
Thank
it's
you.
self-limited.
You
Yeah,
know,
I
Dr.
suspect
Jack,
they.
that's why you never see Len Inman speaking freely. He doesn't need us. You ever speaking freely? He doesn't need us. He doesn't
He's got
need
that.
us.
He's got that
Maybe one
genetic.
day.
He's got that genetic. Everything is fine and dandy gene.
That's
Yeah.
It's
that's
a
right.
good
It
gene.
must be the northern Italian, not the southern Italian.
Whatever it is, it's great.
That's right.
I wish I had it.
Yeah.
It'd do wonders
I
for my
got to hear
golf
the story twice.
game.
I
What's
got to
that?
hear it 2 times. 2 times I got to hear the story.
Oh yeah. Sorry, Jimmy.
No, it's a great story. It was so good I didn't mind hearing it twice.
He's blessed with not being a Jewish chalaria.
Len, did you have any numbness or tingling in your hands and feet when this was occurring?
No, just plain feeling feverish and shaking and chills. And I remember watching a documentary about World War II, and they were talking about the guys in the Pacific. Uh, Many of them got malaria, fighting in the trenches and such, in the jungles. And they talked about severe, violent chills and shaking from malaria. And that's what came to my mind, like, oh, now I know what those guys felt like.
Did you take a temperature?
Yeah.
I took it before I got those severe chills. Before, first, let me preface by saying my normal temperature when I go to doctor visits is usually 97.3. It's kind of on the low side. And so I took my temperature when I just felt kind of flu-like, and it was 99.8. So, not a high fever, but for me, that's like 2.5 degrees above my base. I don't know what it was when I was. I don't think I could have held this, the thermometer in my mouth.
Oh
I
boy.
even, while it was happening, I tried to grab my cell phone and, like Google Zometa reaction. I couldn't even do it. Like I was shaking too much. I gave up on that.
Glad you're okay, Len.
97.3. I knew he was cool.
There you
What did
go.
he say?
97.3. I knew you were cool.
Oh,
I didn't know you were literally cool.
He
not as
stole
cool
my
as you, Jimmy.
line. He stole my line, Len. I just put it in the chat window. He stole my
Oh,
line. Look at that. Never
I didn't
mind. So
see that.
let's just, since we got Jimmy there, Jimmy, are you still on the Paxlovid and how are you doing?
No, the Paxlovid was Monday through Friday of last week. And the worst of it was over for me in about 3 days. But the Paxlovid is a little difficult. I mean, it's only supposed to have the side effect of the strong metallic taste, which I remember from the chemo. It was like that kind of taste, only worse. But it didn't last, but for the course of the pills. But it also made me I thought kind of lightheaded, and it's supposed to give me diarrhea, but didn't do that. I was just lightheaded and confused, and very much like loop run brain, with a lot of forgetting things and using malapropisms and being dyslexic, and I was very reminiscent of that. But then I was probably just suffering the effects of the COVID anyway, because that can go on. It was very difficult to tell where one left off and another began. I knew the drug was doing something to me, and I was glad when it was over. But I was getting better all the time anyway. The worst of it was over in 3 days for me.
And
I'm kind
how
of
are you?
curious. Excuse me, Rick. I'm kind of curious why they even gave you Paxlovid. Did they consider you a high risk person because of your
Well, that's an
prostate
interesting
cancer?
question, John. Interesting question. I have 2 doctors in the family. I have a retired MD, who's my brother, and my brother-in-law, who's a vaccine doctor. And my brother Bob, he said, you don't need it. And the vaccine doctor said everybody he knew that got the new booster didn't get sick, and he did because he put it off. and he said, you want to get the Paxlovid because it won't hurt you to take it. And he also probably oversold that I was immunocompromised, because really, if you look at it on paper, I'm not really immunocompromised. I mean, my treatments are a little bit behind me so far, and I'm in really good health for my age. But I bought into the fact that there is speculation, and not just speculation, but some data starting to accumulate, that long COVID is less likely if you take the Paxlovid. This is what I'm understanding. For that alone, I thought it might be good, because as we all know, long COVID is not much is known about it. And it can be pretty bad. And I'm just waiting for the rebound effect that occurs in about 15 to 20%. But I don't think I'm going to get it. And besides, it doesn't matter, because I never think anything bad's going to happen. So I never thought I'd get COVID. I didn't get it throughout my treatment, and get through the whole pandemic. I didn't get it.
How's Nancy?
She's getting better too. She got it, in the middle of the week after I got it, and she got a lot of coughing, and I didn't. She has much more cough, and I had much more nasal congestion. I'm so glad I didn't get the cough and the raspiness, because I sing, and she can't hear very well. And so it's been blissful, because when I talk to her, she pretends like she can hear me because she doesn't want to say what. And I talk too much. So the combination is working very well.
Oh boy. General Joel, you have your hand up. What words of wisdom do you have for us?
Dr. Myriad at the PCRI conference this past September was pushing Paxlovid for anybody traveling. He says, call your GP, get a prescription so you're ready for it if you get COVID.
Okay, thank you.
Guys, I'm getting dirty looks from my wife. I'm going to drop off. Rick, you want to take over if there's anyone else?
I think we're all done. And
if Fred's wife is done, I'm done.
Okay. Good night, everybody. See you next week.
Good night. Thanks for coming, guys.